So welcome everyone. My name is Professor Mary McCarran, and it gives me a great pleasure indeed to welcome you this afternoon to another one of our online masterclasses with respect to dementia and supporting people with intellectual disability and dementia. Many of you will probably be aware at this stage that we have recently established a National Intellectual Disability Memory Service, which is very much committed to improving the early detection of dementia in people with intellectual disability and offering post-diagnostic supports. And this is the fourth in a series of masterclasses really focused on preparing staff and family members who are caring or supporting somebody with an intellectual disability who has recently been diagnosed or perhaps likely to be diagnosed with dementia. And we really do hope that you find this series of masterclasses useful, and they are available for people to download. And we will be running further classes next year. And the National Memory Clinic, as people may be aware at this stage, it's located at Tallaght University Hospital. I'm serving as the Executive Director, and Professor Sean Kennelly is the Clinical Director of this new service. And this is done in partnership with the Daughters of Charity Disability Support Service and Trinity College Dublin. And we're grateful for the support of the National Dementia Office and the Department of Health for funding this initiative. I'm going to hand over to June O'Reilly, who's going to also work as part of her team at the National Memory Service, and June is going to just do some housekeeping with our participants. So thank you, June. June, you're on, you need to unmute. Yeah, thank you.
Hi, good afternoon, everybody, and thank you for joining us. Firstly, thanks to everyone who's submitted questions in advance of today's masterclass. There's going to be a questions and answers session at the end. And during the live session, if you have any questions that you'd like to ask our panel, please click on the Q&A box at the bottom of your screen and write them there. And we'll endeavour to address all questions that come in, time permitting. As Professor McCarran said earlier, the masterclass is being recorded, as you'll see, but only the presenter and panelists can be seen during the online session. Attendees' mics are muted by default. What we're going to do after the masterclass is send a training needs survey out, and we welcome all feedback about the masterclass series. It's important for us to identify the most critical topics for you, so we'd really appreciate if you could complete this training needs survey, which will be emailed out to you, and this will inform how we shape the future series of masterclasses in 2021. And finally, as you're welcome to use the chat box or email us if you'd like to make a comment or have any technical issues as well. I'll pop the email address in the chat box if you need to email us. Thank you. Back to you, Professor McCarran.
Thank you very much, June. If anyone has any problems in hearing or anything, please do use the chat box just to say hello and report that. But if you have any questions, please use, as June has said, the question and answer box. So we can hopefully we'll get to those during the session. And we have some questions that people submitted prior to the masterclass, and we will have panel members, which I will introduce later on, who will answer and give you some support in relation to those particular questions. So we have the usual format, and it gives me great pleasure now to introduce Evelyn O'Reilly. And Evelyn O'Reilly is a candidate advanced nurse practitioner at the National Memory Service and at the Daughters of Charity Disability Support Service. And Evelyn has extensive experience in the memory clinic at the Daughters. And she's going to, today's presentation, which Evelyn is going to give, is really the language of behaviour and really understanding emotional distress for people with dementia. This is often indeed very, very challenging for caregivers, and often people find it, often some of the most difficult aspect of caregiving. So I'm going to hand over to Evelyn now. Evelyn, if you want to share your screen there and we can get started. So thank you, Evelyn.
Thank you, Mary. Thanks, Mary, for inviting me to participate in this webinar. and I'm looking forward to it going forward. So people living with dementia are deeply forgetful and find it increasingly difficult to interpret their world. They're trying to survive in a world full of uncertainty and security. Their world is different than our own, but is a world we can understand if we pay attention to it. So we have to look at people's levels of anxiety, distress, and frustration and try and interpret what's going on in their world. So looking at the origins of behavior, there's a loss of neurotransmitters occurs normally with the aging brain, and it's happening every day in all of us. But if you have dementia, this loss may become much more significant and result in certain changes in behavior. And we're calling those responsive behaviors. For example, the area of the brain that controls the sleep-wake cycle may be affected, and consequently sleep pattern will become very erratic. People will be up during the night trying to get dressed, rooting through drawers, rooting through wardrobes, attempting to get dressed. And this can be very challenging for caregivers because it's getting everybody else in the house up as well. If the frontal lobes are affected, there will be marked changes in personality and behavior. And we often see changes in personality before we see cognitive changes in people with intellectual disability. How we control and act, for example, is very much guided by the frontal lobes. People may present with disinhibition, removing their clothes, using bad language, all very much out of character behaviors. And this marks a huge change for the person with ID and dementia. The areas responsible for spatial perception may be affected, making it difficult for the person to recognize objects or identify their surroundings. And this is what we call agnosia. The lateral frontal lobes of the brain may be affected, causing the person to get stuck in the moment, causing them to repeat themselves over and over, and indeed causing this distress. We often see people getting stuck in the moment, folding clothes, for example, over and over, looking through their pockets for something that they can't describe, non-stop emptying of wardrobes and drawers, repeating the same stories over and over. And this is due to damage of the frontal lobes. However, only some behaviors can be attributed to the neuropathology of the brain. Many other variables which impact on behavior can be physical causes, psychological causes, and social factors must be considered. Therefore, what I'm saying is we must take on a biopsychosocial approach to care of the person with dementia and intellectual disability. I've just put up this slide because I want you to focus on the blue part of the brain here, the frontal lobes. And we can see here it's identified that the frontal lobes are very essential for planning and organizing, for language skills, for logic, for learning tasks, initiating, starting and stopping movement. For instance, many people with damage to their frontal lobes cannot initiate or complete meals anymore without prompting. Most importantly, though, the frontal lobes are very responsible for personality and regulating behavior. So when dementia spreads from the memory part of the brain, the occipital lobes and the temporal lobes, and move to the frontal lobes, this is where we see significant changes in behavior and personality. Responsive behaviors are very characteristic in the mid stages of dementia. And dementia is characterized by changes in behavior that are often viewed as responsive. Responsive behaviors are behaviors that challenge us as carers, families, or professionals. They are behaviors that we find tough, testing, emotionally draining, and very difficult to deal with. However, these behaviors may not always pose a problem for the person themselves. Some of the common responsive behaviors that we would see and that would be reported to us from day to day are changes in personality. And as I said, these are typically the first changes we see in people with Down syndrome. We can often see agitation and distress, shouting, screaming, verbal aggression, throwing objects, stripping clothes, physical aggression, sleep disturbance is very common, repetitive talking and repeating the same stories over and over, Paranoia and accusations, and this can often cause unrest in the home setting, where the person with dementia is accusing their peers of taking something from them or talking about them. Resistance to care is very common and is very, very difficult and challenging for carers to deal with, whereby people will refuse to shower or will be screaming and fighting and resisting care in the shower. Food refusal can be very common, as is wandering, socially inappropriate behaviours, and sundowning is very typical in the mid stages of the disease. Sundowning is typically seen in the late afternoons or early evenings. We may need to be aware that this is the time when staffing is usually less, and there's an escalation in behaviours which is very contradictory. And the least number of people are available to support the person when these behaviours usually occur, and they're very difficult to deal with. So this is something that services need to look at. Hyperacusis is very common. People with dementia are very intolerant of noise. And it's often the case when we go into some home settings, the telly might be on, the radio might be on, and it could be a very noisy environment. And people just cannot bear noise, people with dementia. It's sometimes described as living in a world where they cannot turn down the volume, and it's very disturbing. We also have to look at delirium, and this occurs frequently in older adults, especially in those who are cognitively and mentally compromised. And in this instance, we have to look at infection, particularly UTIs, chest infections, and chronic constipations, which can exacerbate and be attributed to delirium. Behaviour is a form of communication, particularly in dementia. As Alzheimer's disease progresses and language skills deteriorate, individuals who previously were very expressive, had no difficulty in communicating, may respond behaviourally rather than struggling with verbally expressing his or her basic needs and wants. And we typically see this very much so as dementia progresses into the mid stages. In this scenario, one's behaviour may become the key form of communication as her vocabulary becomes smaller, or abilities to find words and make sentences become more difficult. Word finding problems are becoming increasingly more apparent. To say somebody is aggressive or agitated only describes the behaviour and not the need that they are trying to communicate. It is widely recognised that the behavioural and psychological symptoms of dementia, or as we call them, the BPSD, are more often the person's attempts to communicate. In many respects, learning to effectively communicate with people with Alzheimer's disease can feel like learning a new language. As caregivers, we need to learn the language of dementia so that we can anticipate certain barriers and achieve the ultimate shared goal of being heard and understood. We need to be patient. We need to understand that good dementia care is slow care. If you rush people, if you outpace people with dementia, you cause them distress, you leave them emotionally bewildered, and this will lead to an increase in these responsive behaviours. So why is emotional distress seen in people with dementia? Dementia-related causes include pain, concurrent physical problems like constipation, sensory impairments, infections, side effects to medications, and it's widely reported that people with ID, particularly as they age, have polypharmacy. Polypharmacy is a big problem for this population. Dementia-specific causes often relate to a misfit between the client and the physical and social environment. We also have to look at that the person is very often aware of their declining memory, of their functional decline, and have to adjust to their diagnosis. And this can be very, very difficult for people with intellectual disability. It is important to understand their personality and coping style in order to support them to have the best possible outcomes of care. The person often recognises the emotional distresses of their carers and of their loved ones, And this indeed causes further distress for them too. So looking at the physical factors for responsive behaviours, and the most important one that I think I should highlight is pain and discomfort. It's very important to outrule pain if somebody is presenting with uncharacteristic-like behaviours. Infection is very common in the older population, particularly in people with Down syndrome, particularly, as I mentioned before, urinary tract infections and chest infections. Has the person experienced a recent trauma? Are they experiencing hunger or thirst and can't communicate this anymore? We need to review their medications if responsive behaviours are not responding to treatments. Constipation can cause behaviours to escalate dramatically, so this must also be examined. Dehydration and fatigue, sensory impairment can exacerbate responsive behaviours. And indeed, as I said before, we must look at delirium. And delirium is a very serious presentation and must be outruled. Going back to pain again, it's very important when we're looking at people with dementia and have communication difficulties, we must have some pain assessment tool in place with which we can measure the person's level of discomfort. And I will highlight that now in a moment. Looking at the psychological factors to behaviour, look at the person's overall psychiatric history. Have they got a history of depression or anxiety? Have they had any recent losses in their lives, including their independence, decline in mobility, their coping skills? Have they changed home recently because their current home has outstripped its capacity to offer safe care? Have they lost family or friends? And indeed, looking at the current circumstances of COVID, many people with dementia haven't seen their loved ones or seen their family for a long time. And indeed, we must look at their pre-morbid personality. Social and environmental causes for responsive behaviours include overstimulation. Is the environment too noisy? Is there too much activity going on around them? Are there too many people? And this can cause a huge amount of distress to people who are deeply forgetful. Are the people understimulated? And this is often the case that we see in nursing homes, where we see lots and lots of people in big rooms just sitting around the wall. People who are lonely can present with exaggerated symptoms of dementia. So if they're missing their families, missing their friends, and they can become very lonely even if they're surrounded by large groups of people. Socialization or social isolation from their community, from their day services, from their staff and from their peers can escalate behaviours. Look at the environment. Always look at the big picture. Poor lighting, colour, cues on the walls, misfits between the client and the physical and social environment must be addressed. Inconsistent routine can cause huge amounts of frustration and distress for the person who's deeply forgetful. Routine familiarity is so important for somebody in the mid stages of dementia, and this cannot be overlooked. Regular changes in staff can cause huge anxiety for people, and provocation by others, particularly if their peers are fed up with the behaviour of the person with dementia. And it's more often the case, myself and my colleagues will go into a house to support the peers in that house and offer peer training and offer dementia training to those peers so that they know how to cope with the person with dementia. And indeed, negative attitudes towards people with dementia, labelling, ageism, and malignant social psychology must all be addressed. And now a quick word about pain. Pain can frequently be overlooked as a key contributor to negative behaviour, poor sleep, or agitation. Because pain is subjective and thus dependent on the individual's personal experience and perception of discomfort, recognition of pain symptoms can be missed by caregivers and healthcare providers. This link down below is a link to the DISTAT tool, which is widely used in the UK and in many services throughout Ireland. And I would recommend, if you're supporting people who are having responsive behaviours and have communication difficulties, that you should use a pain assessment tool of some type. I'm just trying to move on here. My presentation is slightly stuck for the moment. We'll see if we can move on now. I'm just seeing if I can.
Yeah. Okay. If you just, yeah.
Oh, there we are. Sorry about that. Sorry. Okay, I'm just going to talk through. I'll see if this comes back, and otherwise I'll just talk through it.
That's just bringing up the distad. It's just bringing up the pain assessment tool, Evelyn. So if you
Okay, I'll get rid of
it.
Yeah, okay. Sorry about that. So the goals of care when dealing with responsive behaviour. We need to act like a prosthetic device that supports the person with what she is able to do. Interventions serve like a memory crutch that fills in for lost abilities. Support the person to be autonomous in spite of lost abilities, and keep stress at manageable levels throughout the day. So it's all about providing ongoing support for the individual. And indeed, prevention is the best medicine in dementia care. Keep stress at a manageable level. Learn to recognize signals that the person is becoming uncomfortable or threatened. And intervening early to identify and meet the need, keeping the person calm and comfortable, is key in dementia care and behaviour. Person-centred care is so important in dementia care. Think about the person behind the illness and not about the behaviour per se. Personal strengths, retained abilities, and long-standing personality traits are so important. Again, rule out physical causes like pain and infection. Establish what's going on within and around the person that has led to the behaviour. Are they upset, uncomfortable? Are they lonely? What is going on in the environment? Is the caregiver familiar with the person and know their life story? People with dementia are so reliant on familiar staff who know them so well and can interpret their needs. It's important to maximise the person's abilities and focus on their strengths. All aspects of care meet the person with dementia's needs and not the needs of the service. Individualised care plans are reviewed regularly and identify emerging needs going forward, and this is critically important. Looking at Kitwood's personhood paradigm is very important in recognising responsive behaviours for people with dementia. Experience of dementia is unique to every individual and depends on the interaction of these 5 key factors. The person's personality, plus their biography, plus their physical health, plus their neurological impairment, and indeed the social psychology of the environment. The neurological impairment is, as we talked about before, the effects of dementia on the brain. And looking at the social psychology, people with dementia need to feel loved, they need to feel needed, and they need to feel valued. We must focus on good relationship-based care in order to uphold the person's unique identity. And this is critically important for people whose lives are slowly eroding away. Kitwood came up with the main psychological needs of people with dementia and what people with dementia need. The most all-encompassing need for people with dementia is to feel loved, to feel wanted, to feel valued. This is the basis of good relationship-based care. People with dementia need to feel comfort at all times, to be pain-free. They need some sort of identity. They need their identity to be upheld at all times. My colleague spoke 2 weeks ago, Pamela, about upholding people's identity with life story work, and this is critically important. People with dementia need occupation, so it's really important to know the person's interests. And inclusion is so important as well. And some of you may be familiar with Bowlby's theory of attachment, and this was primarily used with children who have a huge need for a primary figure in their life, as their life is full of uncertainties for small children. For people with dementia who are deeply forgetful and confused, life is full of new uncertainties, and the need for attachment to a primary caregiver is as great as it was in childhood. And this is why people with dementia, we see them more often shadowing staff around the house, following them around, constantly on their shoulder. And people need attachment in a world that is very uncertain. And this is why this type of presentation is so common towards the latter end of the mid stages of dementia. Looking now at strategies for success, we want to maximize safe function by supporting losses in a prosthetic manner. We want to provide unconditional positive regard for the individual. We want to listen to the person with dementia. What is the behavior telling us? We want to modify the environment to support losses and enhanced safety. And we want to encourage family members and caregivers to participate in ongoing education, support, self-care, and problem solving. Supporting people with dementia is not easy at all. And staff and carers need to look after their own health and seek support that's out there. We need to understand responsive behaviours, but we also need to look after ourselves as carers. Strategies for success include validating feelings and empathise with the person. Remember that actions are often born out of fear, so reinforce reassuring statements such as, I'm here for you, you're safe, and you're always offering hope to the person that we are here to help. Enter into their world and never try to reorientate them, and stay in their present moment, always validating and acknowledging what they're saying. Stay in the present moment when interacting with individuals with Alzheimer's disease. The present moment is all you have, and anticipate certain stressful events or times of day, planning accordingly to minimize anxiety. And we spoke earlier on about sundowning, and this is particularly important here. Try to tie a pleasurable activity to a stressful activity to make it more manageable. For example, put on headphones and play favorite music when cutting toenails or fingernails, because people with dementia don't like having their nails cut, or sing songs while given a bath. And it does work. I've seen this work in a lot of cases. Never attempt to reason or rationalize with a person with dementia. You will not win an argument with somebody with Alzheimer's disease. People with Alzheimer's disease are always right. Stay engaged in pleasurable activities. Individuals will depend more on the guidance and supervisions of caregivers to keep them busy. And indeed, that's why they're always shadowing staff around the house. They want to know, what can I do next? What can I do next? Get familiar with the art of positive redirection. Practice shifting focus and redirecting all the times of stress or escalating behaviours. Develop, for example, a menu of life-enhancing activities. Know exactly what works for each individual. Know their likes and their dislikes. A menu of activities that they will engage with and enjoy will be so purposeful for them. Meaningful life-enhancing pursuits include life story that Pamela spoke about 2 weeks ago, music therapy individualized to the person's taste, hand massage, therapeutic touch, social interactions, videos of significant others, particularly family and friends, and this has been very crucially beneficial during COVID. Memory boxes, reminiscence therapy, validation therapy, doll therapy, pet therapy, and any previously enjoyed activities. But again, it's crucial to know the person very well, because there's no point in trying to start up a new activity that you know in the past they never particularly liked. Understimulation is has huge impact on a person with dementia. If devoid of occupation or stimulation, the person may repeat themselves to alleviate boredom or act out. They may be aggressive, or indeed they may disengage. Episodes of apathy and social withdrawal may be apparent. So we have to redirect and engage in meaningful activities. And again, it's all going back to knowing the person really well and knowing their life story. Human contact is so important. And again, during COVID, we've seen how much COVID has impacted on people with ID and dementia. The person may repeat things as a means of holding the presence of another. The question is unimportant, in fact. Human contact is what is important. Meet the person in their space, have gentle physical contact, and even holding hands can be so crucially important for the person with dementia. Compensate for lost abilities by adjusting our approaches. Use calm, consistent approaches and routines. Do not reason with the person. Do not ask the person to try harder. Do not try to teach new routines, and do not encourage to recover lost skills. Compensate for lost abilities by adjusting routines. Limit choices to one person, to one person the person can make. Offering too many choices can be very confusing. Monitor changes in the environment, and again, keep an eye on noise and overstimulation. Eliminate changes in pace. Routine equals familiarity and comfort. Repetition does not become boring to a person with dementia. And people like repetitive skills like folding towels, sorting out cutlery drawers and things like that. And these are activities that people can succeed at. And look at our adaptive strategies. Responsive behavior are not anybody's fault. When accidents happen or frustration arises, caregivers may often revert to communication techniques that they feel familiar to parenting, raising his or her voice, expressing disappointment, or repeating a certain set of rules or expectations. This approach commonly yields the exact opposite of the desired outcome for the individual with Alzheimer's disease and may increase agitation, irritability, or indeed combativeness. Remember, to avoid correction, use positive body language and listen closely and respond to the feelings or emotions behind the message. Positive redirection will help alleviate the mounting stress or anxiety that the individual may be experiencing. Positive redirection can be a very powerful strategy to help address and diffuse negative feelings and emotions. Dementia affects executive functioning, capabilities of insight, judgment, and reasoning. Therefore, trying to reorientate the person with dementia is pointless and can escalate already strong emotions. For example, if a person is saying, I'm going home tomorrow, and they haven't been home for years, you don't tell them they're not going home. You address the home feelings that they're expressing, and you invite them to talk about home. Tell me about your home, who lived at home, tell me about your family at home. And this is usually very positive. This technique involves trying to gently distract or redirect an individual towards a more calming or pleasurable activity as a way of changing focus towards a new positive present moment. And I've used this positive redirection myself, and it works very, very well. Make simple requests. Bargaining and incentives are common strategies used by many people throughout their lifetime to encourage or reward positive behavior, many times with good success. However, when supporting people with dementia, this strategy is no longer useful or indeed practical. Behavior strategies that are designed around future rewards based on current behavior are destined to be a struggle, since this plan requires a working memory to understand the process. Instead, behaviour approaches should be adapted to meet the needs of the individual in the present moment. Effective strategies are those that primarily reinforce a sense of calm, reassurance, safety, and security for the person. Stay in the present moment. Attempt to positively redirect any negative behaviour and listen and respond to the emotion that the individual is expressing at that moment in time. And to summarise, dementia is incurable, but it is not untreatable. There is so much we can do. It is important to preserve the person's remaining abilities and to promote function as long as we can. We need to avoid unnecessary stress for the person. So as I said earlier, look at the big picture, look at the person themselves, look at their environment, look at what's going on around them. Treat overlapping illness that make symptoms worse that I spoke about earlier. If somebody presents with marked changes in behaviour, it's critically important to look out for infection or constipation. And indeed, provide education and guidance to all families and carers supporting people with ID and dementia. Staff working with this population need to understand and know the person. Staff need to understand dementia and to be dementia aware. And indeed, they need to think ahead and predict the stressors for dementia and make plans going forward. Always, always keep the person with dementia at the centre of care. The most important consideration in caring for a person with ID and dementia is that the needs of the person are paramount. People with dementia need to have or to be stress-free. They need to be failure-free. They need individualised care programmes, and they need consistency without time pressure. I said before, good dementia care is slow care, and this is critically important to remember. And finally, each person's experience of dementia is as unique as their fingerprint. And this is important to remember going forward, supporting all people in all services with dementia throughout the country. Thank you.
Thank you very much. I'll just get you to unshare your slide presentation. Great. Okay. So thank you very much, Evelyn. That was wonderful and extremely informative and really emphasizes the need, I suppose, to ensure that, you know, the environment is stress-free and it's failure-free, and that we look at those things that we can, you know, that really escalate and cause additional stress for the person.
Yeah.
As you rightly say, you know, oftentimes environments are busy places. And if we rush care, if we outpace care, we will overwhelm the individual, as you pointed out. So I think these are really, really important take-home messages. I think that's they are some of the key critical issues. I'm going to introduce you to our panel members who are here this evening with us. We have Dr. Niamh Mulrine. Niamh is Clinical Director at the Daughters of Charity Disability Support Service and is a specialist consultant, mental health consultant, psychiatrist in learning disability, and has huge experience both in supporting the memory clinic at the Daughters and indeed the National Memory Clinic, and a lot of research at the Trinity Centre around the whole area of mental health and mental distress. So lovely to have you with us, Dr. Ryan. So thank you very much for that. Marianne Fallon is with us. Marianne is from the health psychologist, and Marianne works at the Brothers of Charity service in Roscommon area and is also now working part-time at the National Memory Clinic. So we're really pleased to have Marianne, who has extensive experience again in supporting people with dementia. So lovely to have you. So I've just a number of questions, and I might start with you, Dr. Mulrine. And this is a question that has come in. We have tried all strategies for supporting behaviour, and yet the person still appears very distressed and is engaging in aggressive and distressed behaviours. And this person is wondering, what's the role of medication as well, or should we be considering medication?
Okay, thank you, Evelyn, for a great talk. And I think anything I have to say is based on everything that Evelyn said beforehand, so I won't go over that. Absolutely, sometimes behaviour in a person that has dementia can be incredibly complex and really, really difficult, not only for the carers but for the person themselves. And we, whenever possible, need to try non-pharmacological means to support the person. Look at their health, any signs of infection, look at their environment. That biopsychosocial model is so important. As regards medication, like generally we try and avoid medication in people that have dementia if there is no underlying cause found for the dementia. You can have resulting in cognitive changes, increased falls, side effects, and the person is often already on many medications. However, there are some exceptions to that, and it's important to, just as we discussed ruling out any underlying infection or pain, the person with dementia may also have a mental health condition. So we do know in the general population that conditions such as depression, anxiety, psychosis are all more common in people with dementia, and it may be absolutely appropriate to treat that underlying cause if that is found. Diagnosing those can be particularly difficult. So I think I'd certainly recommend looking for some specialist advice and input around that. Even if you do diagnose one of those conditions, there are still many reasons why many of the psychosocial interventions may be very helpful. If you are looking at medication, very, very careful prescribing is required in that somebody that has dementia or may already has underlying neurological differences, so they may react differently to medication. For example, somebody with a Lewy body dementia may become very Parkinsonian, may have great difficulties with certain antipsychotic medication. Also, many medications that have been historically used for people with dementia are actually off license. We have to be just very careful about their use. There is some evidence in the general population that the anti-dementia medications can be helpful in general for the behavioural psychological symptoms of dementia. For people with ID, it's less clear because, again, we haven't had the same numbers and the same number of kind of studies to actually get an evidence base for that. So absolutely so very, very careful, judicious diagnosis and looking at all options. Often the management of BPSD requires a kind of multimodal approach, so you may be trying medication, but certainly you will also be looking at the biopsychosocial aspects and how you can improve things there for the individual. And don't forget, there are things that we can do, like, for example, say kind of sleep wake disturbance. That is something that we see is very, very common in people with dementia. Using a hypnotic generally, if possible, should be avoided. It may be a case of the person being outside seeing some sunlight every day, and there is evidence that can be very effective and as effective and much, much safer than prescribing a hypnotic. So it is complex, and I would always say, if you're not sure, seek advice from somebody that has experience in this area.
Yeah, thank you very much, Niamh. And I think one of the a related question that came in relation to this was, the side effects and contraindications of these medications. And I think you may have probably addressed that. I don't know if you want to say anything additional on that, Niamh.
Again, the absolute caution. I mean, certainly if we do prescribe medications to people that have dementia, we would look at maybe a much lower dose, much smaller increments, and constantly reviewing, constantly checking in, and constantly looking at other other interventions that we can use. There's also a real case, and I know Evelyn touched on there, of deprescribing. Sometimes medication that was absolutely appropriate for somebody 5 years ago may no longer be appropriate, and maybe actually adding to their confusion, adding to their distress. They may be experiencing, say, a dry mouth, blurred vision, urinary retention, these things that many medications can cause due to the side effects. So deprescribing something that we would always look at as well, and that can be very, very helpful for the individual. So it's not always about adding something; it can be about taking things away also.
Yeah, thank you, Niamh. Yeah, because there can be historically, a lot of prescribing historically for many of these population, and the whole issue of sedative burden, of course, needs to be looked at and monitored with respect to probably contributing to further cognitive decline as well, and sense of alertness, etc. So yeah, so I think the real message here is medication, you know, may have some role, but an absolute last resort, but use it if there is some defined underlying mental health problem like anxiety or depression. And I suppose in some ways, just because you have dementia don't need your depression perhaps treated, but we need to make sure that it is depression. So thank you for that, Niamh. But I think the message is quite clear around medication. That's lovely. I'm just going to ask people if they have questions to please put them into the question and answer box rather than the chat box, so that we can pick them up from there. Okay, Marianne, we have had a couple of questions come in, and the first question that's come in is around something I suppose we often experience when we're supporting people with dementia. And this is about a person who keeps on waking at night. They appear to be very distressed and feels that they see someone in the room, and he often will shout and scream. And this is upsetting for him and for others in the house. And if you have any tips or any advice, Marianne, on what you might do there. And I'm going to get you to unmute, Marianne. Thank you.
Sorry, thanks, Mary. Yes, this is something that can develop, unfortunately, very often as somebody progresses through dementia. And as Evelyn mentioned, you need to put yourself in the person's shoes and review what the bedroom at nighttime looks to the person who's sleeping there. So that can be really helpful. Go in and look and see, is the bedroom too dark at night? Do we need to put a low-level light, maybe a sensor light, to help the person to orient themselves when they get up and they're frightened? This can really help a person in just orienting themselves back into the bedroom. Another issue that can arise is a reflection in a bedroom mirror, or maybe somebody has stacked things on a chair, and that looks very frightening at night. So again, with the person's agreement, they can buy a piece of wall to put over the bedroom mirror, or they can restack things in their bedroom that it doesn't look as frightening at nighttime. So these things can be very, very helpful for the person in terms of making the bedroom be less frightening when they wake at night. But as Evelyn mentioned, Mary, it's really important to validate the person, to see it from their point of view. So we don't minimize their distress. If they're waking distressed, we say that we're here for you. Absolutely, you know, you woke up frightened, we'll be here until you go back to sleep. That's really, really important to see it from the person's point of view, to make the bedroom as safe and as easy for them to orient themselves in at nighttime as they can, but also to validate their emotion.
Yeah, I think that's really helpful, Marianne, because it is about, you know, really, again, going back to what Evelyn has said, is really looking at the environment. And as you rightly point out, indeed, many people may see the reflection in the mirror, and something as simple as that can be very distressing for them, or see shadows on the floor. And that's why the use of shiny surfaces and shiny floors, etc., are sometimes not helpful to people and can cause the distress. And of course, again, it's important, you know, if there is evidence or somebody appears to be suffering from hallucinations or delusions, that there is a clear, accurate record kept of that type of behaviors. And Niamh, just, you know, is this something often that we see in dementia, is hallucinations or delusions? And have you any maybe assistance or guidance around that?
Yeah, it absolutely. These things are more common in dementia, and in certain types of dementia, particularly Lewy body dementia, you can get kind of visual hallucinations and more misinterpretation of things in your surroundings, particularly with poor light. I think this is for any of us, think things are more difficult to interpret with poor light. We have to remember also that many people with intellectual disability, particularly those with Down syndrome, also have cataracts, and that can also create difficulties with actually understanding their environment around them. Yeah, it's again, sometimes even like while medication can, as we mentioned earlier, in very specific situations may be helpful, it can also actually result in some extra confusion at night and all this, and may actually be contributing to misinterpreting the environment. So yeah, kind of, as I mentioned, like that's kind of paranoia, delusions, hallucinations, they are all more common in the general population. Again, there's less evidence in people with intellectual disability, but in the general population, they are more common. So all those really practical things are very, very useful. If it also helps for the person to have an ophthalmology check, be really useful just to see how their eyes are working, because again, there could be something there that's actually sort of feeding. When they're more confused at night and there's poor light, it actually just confuses them more. So I think so certainly other reasons.
That's really helpful, and to be very specific in terms of recording what we mean by hallucinations and the examples of visual hallucinations and auditory hallucinations. So I think for carers to keep a record of those as well. So because this often helps, particularly around differentiation of some of the subtypes of dementia, as Dr. Ryan has pointed out. We can see this more often in dementia of the Lewy body type, where we see more often visual or auditory hallucinations. And Marianne, one further final question, and this is in relation to somebody who gets quite distressed if they're having their hair washed and or having a shower. And yes, we have seen that showering sometimes can be difficult. And have you any advice that you might offer in relation to that?
Yes, again, this can be something that happens as a person progresses through dementia, that they may become frightened of the feel of the shower water on their head or on their body, or indeed they might be regressing in their memory back to a time when they had baths and they've actually forgotten what a shower is for, which must be very frightening. So we do see this quite commonly, unfortunately, as well, and it can be very distressful. And again, there's a lot of supports you can put in place to support the person, but also the first thing I always say is look at the routine. I think, Evelyn, you mentioned this, the routine for somebody. We need to not try and lock the person into a previous routine, that we always support them to have a shower in the morning and wash their hair every day. And even if they're distressed, we have to keep going. I think as care staff, we can sometimes forget that we can change things to meet the person where they are. So I would always suggest, look at how often the person needs their hair washed. Maybe once or twice a week is enough if it's quite distressful. And then the type of things you can look at are maybe putting a bath chair in the shower, helping the person sit down. If they tolerate the shower spray on their body, that's great. And they can be asked to tip their head back and maybe use a lovely warm jug of water to wash their hair. So it's not actually, the shower water is not coming on their face, which can be very distressing. That's one way to support the person. If the person is also frightened of the shower spray on their body, which they may be, again, you can use jugs of warm water to support the person to wash, or even if that's still distressful, maybe use some warm face cloths, rinsing them out and using the shower gel and all of that. So I've seen care staff come up with wonderful ideas for people to support them where they're at, minimize that distress, maybe put some music on in the background as well, trying to make it a more pleasant experience. And the most important thing is look at where the person is at. Don't get locked into a routine you always had. Move forward with a more flexible routine that works for the person and minimizes the distress.
Yeah, okay, Marianne, I think that's very helpful. It's keeping, really, again, looking at the individual situation. And very often the like of power showers may not be something that somebody may be familiar with and can be very overwhelming and very overpowering for the person. But as you say, sometimes we as caregivers can be stuck in a routine and everybody has to shower every second day or has a shower every day with their hair washed. And I suppose what we're really looking to do is keep stress to a minimum. I mean, that is the whole object of care, is keeping stress to a minimum and really looking, do they really need their hair washed every day? Can we use a dry shampoo perhaps occasionally? And okay, we need to attend to hygiene issues, but we don't need to do it perhaps if it's really causing somebody distress as often as we may have done in the past. It's again limiting those areas. Evelyn, so thank you very much, Marianne, for that. That's great. Evelyn, a couple of questions has come in here. One is around somebody with dementia and they're refusing food, and they can, if food is being presented, they may try to shove the food away or to appear to hit out at somebody or turn their head away. And is there any, way that, it may be the person is indicating that they don't want to eat, and obviously there is the will and preference issues that we have to look at. But oftentimes we know that people may have difficulty in associating food with purpose. So have you any tips that you might offer here?
Well, I suppose as dementia progresses, people are less active and they require less calories, and indeed their swallow status may be compromised. And it's more often the case that eating meals, 3 meals a day, perhaps just isn't as enjoyable as it used to be years ago. It's very important that staff document people's likes and preferences in their care plans, and